So, you know, one thing one needs to take into account when one is thinking about Waldenstrom's is the many different ways that it can present. It's a disease that, of course, can impact morbidity because of tumor bulk, but also because of the paraprotein that it secretes. In fact, over half the patients that we have to treat, often we have to treat because of the paraprotein that can either affect, the viscosity of the blood, or because the paraprotein can have autoimmune effects. It can impact, by virtue of cryoglobulin deposition. And so one needs to keep all these, events in mind when one is trying to tailor therapy. Then lastly, one of the areas that's become more and more a challenge these days is CNS involvement with Waldenstrom's, because as the patients are living longer, this is becoming a frequent site of relapse. We used to see maybe 1 or 2 a year. Now we see 3 to 4 patients per month with Bing-Neill syndrome. And I just want to, at the end of my talk here, address how, even here we're seeing now progress. So the backbone of therapy has traditionally been CD20 directed therapy, either alone or in combination. With rituximab, we recognize, responses in about 30 to 40% of patients, although seldom do we ever get deep responses. And this is also reflected in the time to progression that tends to be about 1 year to 2 years with single agent rituximab. But it's the combinations that have really allowed us to have more traction, as has been the case in other indolent lymphomas. But keeping in mind that because this is a lymphoplasmacytic lymphoma, rituximab often spares the plasma cell compartment. So as a result, really being able to introduce therapies that target the plasma cell is also important. And for this reason, proteasome inhibitors such as bendamustine or carfilzomib have been very important with combinations, and bendamustine as well. We've seen response rates up to 90%, even deep responses, although, when you look at that VGPR-CR column, don't be fooled. Most of those are still VGPRs. It's very seldom that we're able to attain complete responses. Despite this, though, time to progression with these combinations, at least in the frontline setting, has been in the order of about 4 to 5 years' time. Now, what also guides us in terms of our choice of therapeutics is the centricity of toxicities that we see around Waldenstrom's. Keep in mind that Rituxan can cause an IgM flare. This is really important because if you have patients with high IgM levels and you give Rituxan, you can actually prompt them to go into a hyperviscosity crisis. But also, a lot of the morbidity tied around the IgM, whether it's neuropathy or cold agglutinins or cryoglobulins, can acutely get worse when these patients end up flaring. The other issue is hypogammaglobulinemia, particularly with prolonged use or maintenance usage. We see IgA and IgG levels go down. These patients are already hypogammaglobulinemic, so as a result, you tend to see a lot of sinobronchial infections with prolonged use and even the use of IVIG. And intolerance can also set in, particularly with recurring use. This is not the first infusion reaction that we see. We see this as a late manifestation of rituximab use, and these patients can actually have severe intolerance, and often a switch over to ofatumumab can help these patients. With regard to fludarabine and bendamustine, which are very important drugs as well, we've kind of moved away from fludarabine because of the higher risk of transformation. With bendamustine, we truncate usually therapy at 4 cycles instead of 6 cycles, in which we have seen some amelioration of some of the long-term cytopenias, but we continue to see an MDS rate of around 5 to 8% in many of the studies. And then lastly, bortezomib, which has really been at the heart of much of the therapy as we've transitioned over the last 10 years. We see a lot of neuropathy, even more so than we see in multiple myeloma, and this may have to do with the underlying neuropathy that we see because of the disease itself. So all this, necessitated our ability to be able to innovate, and one of the areas that has really paid off, handsomely for this disease has been the use of whole genome sequencing, which led to the recognition of this highly recurring mutation in Waldenstrom's in the MYD88 gene, this being a mutation that we see in about 95 to 97% of Waldenstrom patients. And much of the signaling work that has come about has been done by this very dedicated Chinese investigator in my laboratory. And some of the central themes of this mutation is that MYD88 is an adapter protein for toll receptors and interleukin-1, these being sensors for infection as well as inflammation. And so when you acquire the mutation, it constitutively turns on a pathway that actually turns on NF-kappa B. And this is mitigated largely in part by Bruton's tyrosine kinase because the inhibitor of BTK is often lost in patients with Waldenstrom's macroglobulinemia. Now, the other player in this pathway is this hematopoietic cell kinase, which is also a master, turn on for BTK as well as the ERK as well as the AKT pathways that also support growth and survival. And both BTK as well as HCK are very potent targets of ibrutinib. And of course, we also know that there are other BTK inhibitors that selectively also target BTK itself. Now, the second most important mutation in Waldenstrom's involves this gene CXCR4. This was discovered by my colleague Zachary Hunter in our laboratory. We see it in about 30 to 40% of patients with Waldenstrom's, and it's fairly unique to Waldenstrom's. We do see it occasionally in other B-cell lymphoproliferative disorders. And this usually is a mutation that goes along with the patients that present with hyperviscosity, with the high IgM levels. It can also promote ibrutinib resistance through enhanced AKT and ERK signaling, and this has been largely worked out by another postdoc in our laboratory, Yang Kao. Now, with this information in mind, we were very keen on evaluating ibrutinib in patients with relapsed refractory disease. This was done with my colleagues Ranjan Advani at Stanford, as well as Leah Palumba at Memorial Sloan. And patients on this trial received 420 milligrams a day of ibrutinib. And in this trial, an essential part was we were genotyping the tumors of these patients, both for MYD88 as well as CXCR4. This is the data that we just updated recently at ASH, looking at the overall response in this trial, broken down by the genotype itself. And what you see is overall response rate of about 90% and almost 80% of the patients achieving a major response. This is particularly exciting since these were really heavily pretreated patients with an average of 2 prior therapies and some out to 9. But within the genotyping subsets, you can see a difference. Those that do not have a MYD88 mutation, the very few that are out there, you really don't see those deep responses. And among those that do have the MYD88 mutation, you also start seeing differences based on the CXCR4 mutational status. You get very, very high major response rates and even VGPRs with those patients that are wild type for CXCR4, but with mutated patients, you see some diminution, but you also see, very importantly, that the time to response also lags behind by many, many months. This is important to keep in mind because sometimes the expectation that we have with ibrutinib is that we expect quick responses, but it's important to know that with this particular genotype, they may be slow, and so patience might be what's important here in order to be able to wait out these responses in these CXCR4 mutated patients. Now, genotype also appears to impact the progression-free survival. We have not reached the median PFS, for this trial, now projected over 5 years in this heavily pretreated population. But you can see among those patients that have been genotyped, those that have the MYD88 mutation but no CXCR4 continue to go on strong. Those that had the CXCR4 mutation, we've hit the median at 42 months, and those that have no MYD88 mutation, drop off very, very quickly. Now, in this trial, we saw no, unusual adverse events. We had our share of, atrial fibrillation. Even with an expanded, population that we've looked at, these patients can still be managed on ibrutinib with medical modifications around their handling because of atrial fibrillation. But the important thing that we also learned was we had no no infection signal in this trial, which is unusual because usually with most of our trials we end up seeing that. And one of the recognitions was that IgA and IgG immunoglobulin levels were not, altered because of the drug therapy itself, something that actually distinguishes ibrutinib versus the other drugs that tend to induce hypogammaglobulinemia. Now, this is our frontline study. This will be actually coming out in JCO very, very shortly, looking at the use of ibrutinib in the frontline setting. And again, here too, the news is all good. We see very high overall response rates, even major responses. These were all MYD88 mutated patients that were on this trial, and this was just by luck because the mutation frequency is so high. And here too, we saw differences based on the CXCR4 mutation status. Those very deep responses, much more in the wild type population and even the time to response was 1.8 months versus 7.3 for the CXCR4 mutated population. Now, one of the bright spots for ibrutinib use appears to be in Bing-Neill syndrome itself. Our traditional management of this has been to use high-dose methotrexate, and even there, it has been fairly ineffective with response rates of around 40% in very short-term disease control. But with higher dose ibrutinib, what we've recognized is very nice responses with Bing-Neill syndrome. We were able in this particular patient to also measure concurrently plasma levels and CSF levels, only to recognize that we do see, penetration of the drug into the blood-brain barrier, through the blood-brain barrier, leading to sufficient levels to be able to induce these long-term responses in these Bing-Neill patients. Now, there are other BTK inhibitors in play in Waldenstrom's. We heard about a lot of these at the European Hematology meeting last week. This includes acalabrutinib as well as zanubrutinib. The thing to keep in mind is that unlike ibrutinib, these are twice daily dose drugs. And of course, there's also vecabrutinib, the Sunesis drug, which is also being evaluated in BTK cis mutated disease. Now, these are just some of the updates of these, again, coming from last week's meeting, looking at the impact of these new BTK inhibitors in Waldenstrom. And in fact, what you'll see is that response rates with these two drugs that were reported out at EHA are essentially, the same as what we see with ibrutinib. Overall response rates, being about 90% in these patients, and similar levels of deep responses and durations of response at this time. What you do see is some differences in side effect profiling with acalabrutinib. You tend to have very similar profile with ibrutinib, with the exception being headaches. Within the first 3 months, these patients can have moderate to severe headache. The mechanism for this remains unclear. However, caffeine appears to be of benefit, and perhaps giving the patients a Starbucks card along with their acalabrutinib may remedy this problem. Zanubrutinib's responses were also reported at EHA. Again, very much in line with what we've seen with ibrutinib. This drug also appears to show differences based on the genomic subtype. And the overall response rates, as was reported, at the EHA meeting, appear to be very much in line with what we see with the other BTK inhibitors. So in the last few slides, what I want to talk about is strategies now to enhance BTK inhibitor activity in Waldenstrom's. And no surprise, and as Andy kind of opened up the meeting telling us about how rituximab has really changed the world of indolent lymphomas, rituximab continues to be an important mainstay in this disease. And so one of the ways that, innovation could come about is just by simply adding in ibrutinib. This is the INNOVATE study that I'm going to talk about. This just came out in the New England Journal of Medicine. There were 150 patients that were randomized to either receive ibrutinib Rituxan or placebo plus rituximab. And the response rates, no surprise, were superior for the patients that received ibrutinib plus Rituxan versus rituximab alone. And we saw this, transcend across the various MYD88 and CXCR4 mutation subtypes. Progression-free survival also was very impressive. As you can see here, the curves for ibrutinib plus Rituxan versus rituximab alone. And this difference actually was more exaggerated in the previously treated patients because almost all of them, had seen rituximab. But this is really where the story is, and why I think this, paper got into the New England Journal of Medicine, is recognizing that perhaps that CXCR4 mutated subtype also appears to benefit with the addition of rituximab. And with longer-term duration, we'll be able to see how real this is, whether or not there is a separation of curves based on CXCR4 mutation status. Now, of course, what's left, for understanding after this study is ibrutinib Rituxan better than ibrutinib alone? Well, we've been down that road before with the Helios study, and I think there is some room for skepticism because ibrutinib alone has done, incredibly great things for Waldenstrom's. And the necessity for rituximab, I think, still remains to be clarified. Now, another way that we're hoping to also advance the BTK inhibitor field is to actually target CXCR4 itself in these patients that are mutated for CXCR4. There is a monoclonal antibody called ulocuplimab. It actually binds to the CXCR4 receptor and it blocks its engagement with CXCL12, its corresponding ligand. This trial is ongoing. It's a phase 1, phase 2 study. And so far, I'll tell you, we're very excited by the results. We've seen those major responses come very, very quickly in the patients that have received, both drugs together. Now, the last area that I just want to talk about is targeting BCL2. BCL2 itself is overexpressed in Waldenstrom's patients, particularly among those that are MYD88 mutated, regardless of their underlying CXCR4 mutation status. We just reported this trial at EHA, which is a phase 2 study of venetoclax in previously treated patients. And this was the study schema where patients were started on drug at 200 milligrams per day and dose escalated to 800. After the initial cohort came in at 200 that showed no tumor lysis, we were able to now start patients at 400, going up to 800 milligrams a day. And part of the study design was really to look at all comers with previously treated disease, and this included about half the populace that were patients that had seen a prior BTK inhibitor. Despite this, what we saw in the trial, very excitingly, was that the overall response rates were very, very high with venetoclax. No prior ibrutinib treatment was 93%. Prior ibrutinib treatment was 80%. We did see some differences, again, with the depth of response being impacted by no prior therapy. And even among the CXCR4 mutated patients, overall responses tended to show very little difference, except, again, with the depth of response being better with CXCR4 wild-type patients. The drug was very well tolerated in this study. In fact, the primary adverse event was neutropenia, which was seen really in a handful of patients and managed with G-CSF. And importantly, we saw no clinical TLS. We did have one patient with laboratory TLS that was easily managed, and no IgM flare and no deaths on this study. Now, one of the reasons why we're very excited about the use of venetoclax, and it's very appropriate these days as we're seeing, the World Cup being played out, is because BCL2 really does oppose the activity of many drugs, including that of ibrutinib. And this was very nicely shown in a study by my colleague Yang Cao, which we published many years ago in BJH. And in fact, what we did here is we modeled out Waldenstrom cell lines, those that had no CXCR4 mutation as well as those that didn't. And what you see very nicely here in these Western blots that try to pick up, evidence of apoptosis by measuring either PARP or caspase-3 cleavage is that if you add ibrutinib, you see a little bit of a wisp of, hint of apoptosis. You add in venetoclax, you see, again, a little bit, of a wisp of apoptosis, but it's really when you add these two drugs together that you see really a very nice apoptotic effect. And this is also true in primary cells of patients that have not been previously treated, as well as those that have been on prolonged ibrutinib therapy. So the current trial that we're now, about to start off with is combining ibrutinib and venetoclax in treatment-naive patients. And really the goal of this study is to see if we might be able to reach even an end goal of a definitive timed therapy where the two drugs can be used together, and then we can, give the patients a pause in therapy. So just to kind of summarize up, a treatment approach for the treatment of Waldenstrom patients, it's important to recognize that right off the bat, if you have a patient who's presenting with either hyperviscosity, severe cryoglobulins, cold agglutinins, peripheral neuropathy, plasmapheresis certainly is what you want to, do for these patients. And then based on their genotype, you can handle these patients, selectively. Those that have the MYD88 mutation but no CXCR4, ibrutinib represents a optimal choice, so long as they don't have bulky disease. If they have big bulky disease, we tend to defer to bendamustine Rituxan. If they have amyloid, we tend to defer to proteasome inhibitor-based therapy. Or if they have IgM peripheral neuropathy, the mainstay has been to use rituximab alone. In the setting of those that have the CXCR4 mutation, the same caveats can apply, except here too, based on the INNOVATE data, the concurrent usage of Rituxan and ibrutinib may be more appropriate for these patients. And lastly, the wild-type population, MYD88 wild-type, represents still a challenge. These are patients that have shorter survival, and they also show higher risk of transformation to aggressive lymphomas. This has to do with their underlying genomics, because many of the mutations that we have found in this population are very similar to those what we see in ABC, DLBCL. In the salvage setting, one can consider repeating primary therapy if a response was seen for over 2 years. Otherwise, much of the same caveats can apply, except here too now we see with the activity of venetoclax, in these patients, that this would be appropriate to consider, particularly for those patients that have been previously exposed to ibrutinib. Other options include everolimus, particularly for the multi-treated therapy patients, nucleoside analogs for non-autologous stem cell candidates, and then very lastly, you'll see that there's this very small group of patients that you can consider autologous transplant, but they have to demonstrate chemosensitive disease for optimal activity. And also the patients with amyloid, we also tend to consider auto transplant in their management as well. And in concluding, I just want to acknowledge all my colleagues, our basic science, translational, as well as our clinicians, including my colleague Jorge Castillo, that have helped make all this progress possible. Thank you so much for your kind invitation and for listening.